Hello and good morning, everyone, and welcome to the last lecture of hematology. That is about multiple myeloma. Um, we had covered in hematology, we had covered all the rest of the topics. We had covered anemias, we had covered the clotting disorders, we had covered now the rest of the, you can say, the blood cancers or the neoplasms of blood. So now this is the last topic, which is multiple myeloma. So, what is multiple myeloma? By definition, multiple myeloma is a cancer of plasma cells, or you can say it's a neoplasm of plasma cells. And what are plasma cells? What is plasma cells? Very important to understand for many who either forget immunity, same like me, or who never studied that. So, plasma cells, of course, they are white blood cells, and their main function is to secrete antibodies. Okay, and antibodies. Okay, this is their main function. And when the body secretes antibodies, I think we must know about this thing as well. In response to antigens, and what is antigens? Antigens are those parts which are uh, there, which are present on different viruses, bacteria. Okay, and they are the one which are processed by antigen presenting cells, and then they are presented to the body, and the body started producing antibodies. And these antibodies go and target the antigen, and of course they neutralize them, and this is like the whole process. So when there is overproduction of these cells, they are called as multiple myeloma. Okay, and uh, the important part now to understand multiple myeloma, because one of the cause or one of a condition which can change into multiple myeloma is uh, MUGS, MGUS. Okay, so I will start my story with MGUS. So what is MGUS or MUGS? Is monoclonal gammopathy of unknown significance. Okay, this is monoclonal gammopathy of unknown significance. Okay, now what we are going to study here is what I told you. Uh, Many of the patients, they have monoclonal gammopathy of undetermined or unknown significance. And again, this one is a problem related with the plasma cells, which are the antibody producing cells, of course. So, what happens in these patients? There is presence of M protein. Antibodies are proteins, okay, in serum. And there is presence of M proteins in serum, but there is no clinical or laboratory evidence of a plasma cell dyscrasia, okay, or any lymphoproliferative disorder. So now see, what is plasma cell dyscrasia is like when one kind of plasma cell is present in the blood, like in too much amounts, uh, we call it as plasma cell dyscrasias. Like, of course, they are proliferating too much. One cell line is proliferating too much. That's it. Okay. Uh, this is so common condition. Like, you can say it is present in 5% of people who are greater than 70 years of age. Okay, so this condition is so common. And the other thing is, this condition is asymptomatic. Okay, so what I'm saying, that there is presence of M protein in the serum, but there is no clinical or lab evidence of any other condition. Okay, so of course, like the clinical there will be no clinical features when there is no symptoms, for the patients are asymptomatic. So of course, the patients, they don't present with any symptoms, like they are asymptomatic. And it is present in 70% of the people, 5% of the people who are more than 70 years of age. Okay, so common. Now what happened, how we diagnose this condition, how the diagnosis is done, is basically by I will show you some of the photographs. How we catch, like, either there is any kind of abnormal, like, overproduction of the things are there or not. Okay, so for example, if we found the M protein in the serum, uh, or you can also say serum monoclonal protein. Okay, so, and one thing is, like, there should be less than 10% plasma cells in the bone marrow. And the third thing is, there is absence of CRAB. Absence of, again, this is a mnemonic, CRAB. C is for basically hyperkalemia. Okay. R is for renal insufficiency. You will understand the things, what I'm talking about, once we will start with multiple myeloma. A is for anemia and B for bony disease, right? Okay, so there's absence of CRAB. Okay, so M protein is serum should be less than, in these patients, 30 gram per liter, right? So there is absence of CRAB, or hypercalcemia, renal insufficiency, anemia, and bony disease. Okay, when the patients, they have these things, up to 1% of patients, okay, basically develop hematologic malignancy within, or each year, you can say. Okay, so what happens, by the way, with these patients is, patients who have the M protein of more than 15 gram per liter, they are had higher chances of developing the malignant transformation. Okay, so, or the patients who have some, you can say, increase or abnormal serum free light chains. Like, again, what are these chains? I will let you know. So anyone, who have this thing, or who have monoclonal gammopathy of unknown significance, and whenever we found in these patients, like the patients we found this M protein, they are at higher chances of developing hematological malignancy within a year. So what we do, we keep on taking their annual history. Okay, like we keep on monitoring them. We keep on doing their physical examination. We keep on doing their investigation like CBC, very helpful. Creatinine, okay. Calcium, see, hypercalcemia. Albumin levels, serum, protein, electrophoresis, okay. We keep on doing these investigations. Why? Because many people who have MUGs, okay, they can change into multiple myeloma. Okay, so talking about multiple myeloma, it is one of the condition, okay. Multiple myeloma is, you can say, a condition which every medical student should know, because a lot of questions come from this topic in different exams. Okay. So see, in MUGs there is absence of crab. Things will make sense when the multiple myeloma is there. There should be presence of crab. Okay. MUGs is absence of crab. In multiple myeloma, there should be presence of crab. By definition, multiple myeloma, you can say it's a malignancy of the plasma cells. That's it. Very easy, right? But the complete definition is it's neoplastic clonal proliferation of plasma cells, okay, producing a monoclonal immunoglobulin resulting in end organ damage. See, now when the body started producing one kind of plasma cell, one kind, see, because there is monoclonal, just one clone of immunoglobulin is increasing too much that now it's starting damaging the organs. It is called as multiple myeloma. Okay, let's put a photograph just to show you what I'm talking about is this one, right? Okay, guys, see this one. Okay, what is electrophoresis, by the way? See, in our blood there is a lot of proteins, in our urine there is a lot of proteins. So I'm telling you a very, very, very simple way. They take a special kind of paper, okay, for example this paper, they put the blood here and then they pass a current, right? That's what is called as electrophoresis. Now due to that current passing, guys, I'm like what I'm doing, I am explaining you this thing in the most easiest way that someone can, right? So they can pass a current, and when the current is passed, what happens, that the things will start moving because the proteins have charges, negative charge. Proteins are negative charge, right? So they will start moving, and anything which will move will according to their weight. Okay, if something is heavy, will move less, but if something is light, it is going to move more. Okay, so it is the easiest way to tell you how electrophoresis work. In the normal people, if you can see over here, there is albumin, there's alpha 1 chain, there's beta 1, alpha 2, beta 1, beta 2. Okay. By the way, like in reality, the alpha is made up of, this is albumin, right? This one is albumin. The alpha chain is alpha 1 and alpha 2. Basically, alpha 1 chain is formed by, this is all the antitrypsin we have. Alpha 2 is formed by the haptoglobulins, macroglobulins, antiplasmin, plasmin, ceruloplasmin. Then beta This band is formed by the transferrin and LDL, and then there is the gamma chain. This gamma chain is formed by immunoglobulins, which are IgA, IgD, IgE, IgM, game. Now, see the normal people. There's a lot of, so see the green one is for the normal people. You can see over here a lot of albumin, few alpha chains, few alpha 2 chains, then few beta chains, and then few gamma chains. But whenever there is multiple myeloma, what's going on? That they have too much gamma chain. So what they have? Too much immunoglobulins, and this immunoglobulins is basically proliferation of one single colon. The red one is multiple myeloma. See, there is a big peak over here, this one, and then small, but see, there is a big peak over here, which is the gamma chain peak, right? So this is how, this is called as serum protein electrophoresis, or SPEP. This is urine protein electrophoresis, or UPE, right? So this is how we diagnose multiple myeloma, or this is what you can say, what is the abnormality in multiple myeloma. If you can get this concept, guys, the things will become easy for you. Okay, so simply see, the proteins, they started migrating, and as in multiple myeloma there is overproliferation of monoclonal immunoglobulins. See, the band is so darker over here, right? Okay, the band is so darker. So basically, the immunoglobulins, they are consist of heavy chains, IgA, IgG, IgE, IgM. They are heavy chain. And then there is light chains. Light chain is kappa and lambda. Okay. So when the gamma chains, or when the gamma globulins are elevated, we call that condition as what? Hypergammaglobulinemia. Okay. When the gamma chain is decreased, so what is this one? This is hypergammaglobulinemia. When this one is reduced, we call it as hypogammaglobulinemia, right? So these are the things. And what happens, uh, like in the gamma zone, like when we interpret this thing, if this swelling is, or this peak is so much broad, okay, so it means like it is polyclonal, like different clones are too much proliferating. Okay, so of course then it will be very much broad. Okay, so in polyclonal gammopathy it will be broad. Okay, so for example, I will tell you, in different infections, in chronic liver disease, in systemic lupus erythematosus, this chain will be very much broad. Okay, but whenever it is very narrow, like in this case, okay, uh, it is also called as restricted band, or M spike. Okay, this what, M protein. Okay, this is also called as what? M spike. So M spike basically occur when there is monoclonal proliferation, like just one of the gamma chain, or gamma, like this gamma band, one of the thing is elevated. We call it as what? Monoclonal proliferation. So see, MGUS can be diagnosed by this way, right? Multiple myeloma can be diagnosed by this way. Okay, so this is how the things work. If you understand this thing, guys, the thing will be easy for you to understand what is MGUS, what is multiple myeloma, what is, like, one more thing we will study is called as Waldenstrom macroglobulinemia. Okay, this is what happens in the patient with multiple myeloma. Okay, so usually it is single clone of plasma cells. Okay, rarely it could be biclonal. Okay, now if you know the definition, then of course we have to like I will not go in too much detail about pathophysiology, because otherwise again this lecture will not be finished in 1 hour. Of course, like, okay, the incidence of this gamma globulinemia is more common in males than females. Okay, and the risk of getting multiple myeloma basically increases with age. Okay, and it is the most common plasma cell malignancy. Okay, so what's there? It is simply malignant plasma cells. It is monoclonal antibody proliferation, and 95% of the times, okay, it produces M protein, okay, or M spike. M protein or M spike is there. Okay, so uh, now this M protein or M spike can be monoclonal most of the time, immunoglobulin, okay, which is equal to, like, you can say identical heavy chain plus identical light chain. Okay, if you know what immunoglobulins are made up of. Okay, or it can be only light chain. Okay, but there is single one. Okay, and most of the time, it is IgG. 50% of the time it is IgG, which is the one which is affected, which is involved. Okay, IgG. After that, IgA, 20% of time. After that, it could be IgD, but not so common, guys. You can say 2% of the times. Okay, and IgM is the last one. IgM, you can say less than 1% of the time you'll find this one. Okay, so what happens, like they keep on producing free light chains, or light chains alone can be found. So in the serum, what we found is either an increase in the quantity of either kappa or lambda light chain. Okay, so what happens in the serum of these patients, we can found kappa or lambda light chain. Okay, because most of the time, it is the light chains which are overproducing. Okay, and in the urine we found Benz Jones proteins. Okay, these are abnormal proteins which are present. Okay, so okay, if you understand this thing, then we'll go and discuss clinical features of multiple myeloma, right? Okay, so in the clinical features now, see, there is monoclonal proliferation of one cell line, right? This is what's going on. This is what is going on, right? Bone marrow, where the plasma cells are made. This is the bone. These are the normal plasma cells, and these plasma cells are making antibodies, right? And see, these are the abnormal plasma cells which look bigger, and they make a lot of antibodies, or the light chain or the heavy chain, whatever, right? So first of all, remember the bone is producing these things. So the first thing the patient having is bone disease. Okay, they have pain, usually back pain. Okay, they have pain, usually back pain. Same like all the cancers, they have bony tenderness. When you're going to examine them, you'll find tenderness in their bones. Now their bones become weak, so they may have pathological fractures. How we define pathological fracture? When the bone can get fractured with a force which should not cause fracture in a normal person, we call that thing as pathological fracture. Like normally, when you go for groceries, you can pick 15-20 kilograms in one hand and you can walk back home. But if by picking, you can say 10 kilogram packet in your hand, if you have a fracture of the vertebral column, that's a pathological fracture. Okay. So this is okay. What happens? Multiple myeloma basically give lytic lesions in bones. Okay. Of course, which are visible on the X-rays and MRIs and like this, right? So lytic lesion on the bones, like they involve the skull, spine, okay, long bones, and ribs, as well as ribs, right? So they give like all these things. Wait. You can see over here. Okay. This is a lytic type of lesion, what you can see. See, this. Okay. So we call it a salt pepper type of X-ray, right? So this is X-ray of the skull. A very typical thing, you know, what we can see in the patients of multiple myeloma. Okay. So anyhow, okay, so now there is also like increased bone resorption secondary to osteoclast activation, okay, in these patients. Now again, guys, the same story which I'm telling you from the start of hematology. When the bone marrow is producing some cells in a high speed, other cell lines will be depressed. So what will happen? The patient will be having anemia. Okay. What are the features of anemia? I think you guys now should know. Again, the same story: weakness, pallor, fatigue, tachycardia, dyspnea, dizziness, all the stuff, right? So why anemia is occurring? Because there is bone marrow suppression, right? Because the bone marrow is producing other cells in higher speed. Okay. The patient present with weight loss. Okay. Again, they have more infections. Why? Because the bone marrow is not producing normal white blood cells, right? The plasma cells are not working fine, not making antibodies fine. So usually these patients have most infection from gram negatives as well as streptococcus pneumonia. So why? Because the normal plasma cell function is not there. Okay. Now guys, think about crab. The crab should be there. So what is should be there is hypercalcemia. Okay. Why there is hypercalcemia in these patients? Because there is increased bone turnover. See this one. This thing is going on in all the bones. Okay, so they present with hypercalcemia. Now, if you know the features of hypercalcemia, whenever there is hypercalcemia in any patient, they present with nausea and vomiting. They may have constipation. They may have polyuria. They may have polydipsia. They may have confusion. And when it becomes too severe, there are many other features which can be there. Are renal injury or renal failure can be there. Okay. Why there is renal injury and renal failure in these patients? Simply because there is abnormal proteins which will go and get deposited in the kidneys, and when they are going to go and deposit into the kidneys, the kidneys will be damaged. Okay. So the proteins which are abnormally circulating in the blood, they will come in contact with the kidneys, right? So in multiple myeloma, of course, this monoclonal proteins which are keep on producing, okay, or the free light chains which are secreted by uh, by the body, okay. These free circulating light chains will do what? They will go to the kidney, okay, and the kidneys will get damaged, okay. Uh, and when the kidneys will be damaged, simply uh, it can the patient will present with renal disease or renal failure. And of course, there is hypercalcemia which is going on. They can also may cause the formation of kidney stones, okay, calcium stones in the kidney, okay. So, and all the condition, guys, all the chronic conditions can lead to development of one more condition called as amyloid or amyloidosis. And what is amyloidosis? That is deposition of abnormal protein in different parts of the body. Okay, so different abnormal protein materials that have almost similar structural organization, but they are deposited in different tissues. Okay, so amyloidosis can be found in multiple myeloma as well as many other conditions. For example, Alzheimer's condition. There is again a different type of the proteins are deposited in different parts of the body, right? So it can occur. So renal injury, renal failure will be there. So C, anemia is there, hypercalcemia is there, C. R, renal failure is there, A, anemia is there, B, bony lesion. Yeah, in the previous, bony lesions are there, right? So if these things are present, so it means like crab features are there, right? So renal disease is there. Now platelets are less, bleeding. Okay, bleeding can be there simply because why? There is thrombocytopenia. So when bleeding can be there, what kind of bleeding will be there when platelets are not there? I told you before in previous lecture. Superficial bleeds. Think about petechias, purpuras, ecchymosis, epistaxis, and in the case of females, menorrhagia. Right? So think about these things. Now, there can be extramedullary outside the bone marrow plasma cytoma. Okay. So, what's going on in this one? Like these are the soft tissue mass composed of plasma cells, okay, and they can present anywhere. And rest is all the same story, guys. Hyper viscosity. If you know what is this one, so uh, go and check my previous lecture, right? Hyperviscosity syndrome. What is that? Sorry, okay. And How hyperviscosity patients can present. They present with, see, the blood is blocking, stopping everywhere. Headache, stroke, angina, myocardial infarction. Why there is hyperviscosity syndrome again? Why? Because there is abnormal proteins, M proteins. Okay. So amyloidosis can occur, right? So simply like in amyloidosis, as I told you, there will be deposition of abnormal protein in different uh, organs, right? So what will happen, guys, when the abnormal protein can deposit into the heart? So it can lead to cardiomyopathy. The heart cannot expand properly, or you can say diastolic cardiomyopathy. Diastolic cardiomyopathy, right? Cardiac arrhythmias can occur, syncope, death can occur. Uh, Whenever this abnormal proteins are going to deposit into the GIT, malabsorption can occur. Tongue can become big and beefy. Okay. Neurological involvement can be there. Carpal tunnel syndrome can occur. Okay. So many other features, due to amyloidosis can occur. Okay. So okay, and many of the patients they present with neurological um, condition, disease as well. What happened is like they have muscle weakness, pain, and paresthesia. Okay. Why? Because many of the times that their vertebral column get fractured. So whenever there is vertebral column can get fractured, they may have either radiculopathy, means the nerve root is compressed, or they may have spinal cord compression, which is a medical emergency. Okay. There could be radiculopathy, the nerve root is compressed, or there could be spinal cord compression. It's a medical emergency, remember, guys. Spinal cord compression is a medical emergency. So see, there is a lot of features of clinical features of multiple myeloma. Okay. There is just abnormal proliferation of plasma cells, which is basically causing a lot of abnormalities in the body. So again, investigations in this one is a long list of investigations are there. Start from the basics, guys. CBC we will do. What you will found? Anemia you will found. Thrombocytopenia you will found. Leukopenia you will found, right? Anemia you will found. Thrombocytopenia you will found. Leukopenia will be found. You can do blood biochemistry. What are the things we'll found in this one? Increased calcium. Okay, makes sense. Okay, sorry. ESR CRP. Okay. Of course, they will be raised. Okay. ESR CRP will be raised. Okay. Now, proteins are overproduction of proteins are there. So think about there will be decreased anion gap. Why? Because the proteins are negatively charged, guys. Right? If the kidney injury is there, creatinine increased. If the kidney damage is done, we can check the albumin levels. We can check the beta 2 microglobulin levels. Okay, and we can check protein protein levels in urine. to check for the kidney damage simply, right? Now the investigation, guys. You have to catch the monoclonal proteins, right? So when you have to catch the monoclonal proteins, what investigations you will do? I already show you that one. SPEP, serum protein electrophoresis. Serum protein electrophoresis, and you will do what? UPEP, urine protein electrophoresis. What you will do? Urine protein electrophoresis. Again, the same thing, guys. This is the photograph of SPEP and PEP, right? Okay, one thing is which we can do to catch the monoclonal protein is called as immunofixation. Okay. Now, what is immunofixation? Maybe I can find the thing. Okay. I'll leave that. Actually, I was trying to find something. Okay. So, immunofixation is basically to identify the immunoglobulin type, right? And also, like simply, it can also identify which light chain is the one which is there, right? Like, routine examinations cannot catch proteins. What kind of protein is there? For example, if we are doing, for example, urinary dipstick, if there is proteinuria, of course it can tell. But if it cannot tell, like either the light chains are there, either what kind of things are there. Okay, so you can say urine dipstick only detects albumin. To detect the what kind of light chain is there, we have to do electrophoresis or immunofixation. Okay, these kind of tests. Okay, now one of the tests which is called as serum light chain quantification. Simply, this one is to calculate the ratio of light chains, kappa and lambda. Two light chains are there. One is kappa and one is lambda. So, for example, the condition where when the kappa chains are more than lambda, that condition have better prognosis simply. So this serum-free light chain quantification is to see what kind of light chain is more. Either it's the kappa type, either it's the lambda type, right? Rest of the investigations are again same like the other cancers. We can go for bone marrow biopsy. Okay. What we'll found like there is more than 10% of plasma cells. If you don't remember, in this one, in the bone marrow, there's less than 10% of plasma cells. So in this one, there is more than 10% of plasma cells, and they look abnormal cells. Okay, they look abnormal cells. Again, I will show you how they look like. Okay, but, I will show you how they look like. This is how the plasma cells look like, big and abnormal. Okay, this is how they look like. So of course, like once we get the plasma cells, then we can send what you can say that though these cells for cytogenetics and fish. Okay, we can do X-rays, guys. Of course, I already talk about that. We can found the lytic lesion. We can found the osteoblastic activity. You can do MRI. You can do CT scan, especially when there is vertebral column, vertebral bodies fractures, or simply vertebral body fractures or spinal cord compression, right? So we can do like multiple investigations in these patients just to find what is the cause. So there is an international myeloma working group criteria for diagnosis. For example, number one, if there is serum or urine monoclonal protein. Number second, if we found plasma cells in the bone marrow or a plasmacytoma. And number three, if we found crab. Okay. So this is like one of the things. The last thing which we have to study about this one is treatment, right? Treatment. Treatment is non-curative. Sad and bad news, by the way, in the start. Okay. So when the treatment is non-curative, so we should have treatment aims. Okay. So the treatment aim is to just improve the life quality, improve anemia, reverse the renal failure, decrease the pain, reduce or slow down the speed of progression, and increase overall survival. Okay, these are the treatment aims because the treatment is non-curative. One of the things which we can try is autologous stem cell transplant. Okay. But the bad thing is, we can just do it in the patients who are less than 65 years of age. And, the mean age of diagnosis of multiple myeloma is basically more than 65 years of age. Okay. And there's a lot of side effects. We give 4 to 6 months of like treatment, immune treatment, and we give drugs which are basically cytoreductive or who destroy the cells, who decrease the cells, who decrease all the abnormal cells. Okay, and then we go for that. Okay, so of course, like this is the only choice. This is a choice. First of all, we can just try in young people, younger than 65 years of age, and a lot of treatment is there, like pre-treatment protocol is there. So anyone who is more than 65, we go for chemotherapy in more than 65 years of age. Okay, or anyone who is transplant, you can say transplant ineligible. Okay. So what kind of chemotherapeutic drugs can be used? Again, there are many. Malphane can be given. Okay. Prednisolone can be given. Cyclophosphamide can be given. And many others. Newer drugs are also there, right? Which we can give. So there is a drug called as bortezomib. So we can give dexamethasone and bortezomib. Dexamethasone plus bortezomib. Okay. If there is acute renal failure or there is light chain disease. Okay. Rest is all supportive treatment, guys. Supportive. For what kind of supportive treatment you have to give in these patients? What they have. If they have lytic bony lesions, so give them bisphosphonates. Ask them to take them upright and keep on sitting after taking tablet at least for half an hour. Okay. So if they have like bony lesions, lytic bony lesions, if they have osteopenia, you can give them bisphosphonates. If they have too much bone pain or spinal cord compression, we can give them radiotherapy to reduce their pain. If they have vertebral fractures, okay, and they have too much pain, so we can do kyphoplasty. Okay, surgery to treat that. If they have hypercalcemia and they are dehydrated, provide them hydration for hypercalcemia. calcemia. Okay, so things like this treat anemia. Okay, antibiotics for infection. Okay, so things like this. Okay, so the thing is, whatever you will give, many of these patients, they relapse, they again the disease started growing and disturbing, and there is a lot of morbidities, right, in these patients. So the disease is not so good, and the median survival is around 3 to 7 years time. That's it. And again, we use the same scoring system I told you before, international staging system, ISS, to stage these patients. The last condition which we are going to study, and that is called as Waldenstrom macroglobulinemia. Okay, and as I told you, what is hyperglobulinemia? So basically, this is the proliferation of lymphoplasma cytoid cells. Okay, and they have the presence of monoclonal IgM paraprotein. Okay, what they have? IgM paraprotein proliferation. Okay, monoclonal, of course, monoclonal IgM paraproteinemia. So what happens? Like again, this is disease of old age, and one thing, why I'm studying, why I'm teaching with this condition is simple, that this is the disease of old age. Okay, and the symptoms they have is again the same thing: weakness, fatigue, bleeding, weight loss, recurrent infections. Okay, which is this thing. Basically, I teach you hyperviscosity syndrome. 85% of the patients with hyperviscosity syndrome have this disease. So you can say this is the most common cause of hyperviscosity syndrome in simple ways, and that's why I'm teaching you this thing. They usually say that Waldenstrom's macroglobulinemia is a triad of anemia, hyperviscosity syndrome, and plasma volume expansion. Okay, so they have neurological symptoms as well, they have peripheral neuropathy symptoms as well, they have cerebral features as well, they have splenomegaly, hepatomegaly, lymphadenopathy, retinal lesions. Think about this thing, guys. Hyperviscosity syndrome. 85% of patients who have hyperviscosity syndrome have basically Waldenstrom's macroglobulinemia. Okay. So the key thing or the key game in this condition is what? We must avoid hyperviscosity syndrome, because all the features I told you, some of the basic features like anemia, bleeding, infections, fatigue, pallor, all these things are common things, right? I think I am talking about these things the time we started studying hematology, right? So the other things are all the features of hyperviscosity syndrome. They go into congestive heart failure, they go into all these features, neurological features. Okay, it's because of this thing. So what's the reason behind that? Why they have hyperviscosity syndrome? Because this one is IgM paraprotein, or proliferation of IgM type. Okay, and if you know, IgM is largely present in intravascular space or in the blood, in the circulation, right? So that's why these patients have uh, largely, sorry. So these patients have hyperviscosity syndrome, right? What is the investigation, guys? Again, the same thing: CBC, ESR, CRP. Okay, we will go for these investigations. Bone marrow biopsy. Makes sense, right? And bone marrow biopsy will show you what? Plasma, cytoid, lymphocytes. Okay, so we can go for CBC, ESR, CRP. You can check for bony lesions. You can do electrolytes. Hypercalcemia will be there. Hypercalcemia is will present in almost all kind of cancers. Okay, so all these investigations, like many other investigations, can be done, but not needed to like cover them. So what is done again? We do chemotherapy. Okay, one of the name of the drug is called as bendamustine, right? By the way, it's a new type of drug, guys. Okay, bendamustine. Bendamustine is a newer type of a drug uh, which is present. So what happens, like this bendamustine is used for treatment of many other cancers. Okay, and of course, like all these medications are very expensive. So uh, bendamustine can be given, and there are, you can give other drugs or like cytotoxic drugs like chlorambucil, right? Can be given. Fludarabine can be given. Okay. Rituximab can be given. Okay, and any combinations can be given as well. We can give them corticosteroids. Okay, and one very important investigation which I'm talking about last, if any patient is having hyperviscosity syndrome, and why they have hyperviscosity syndrome, because there is IgM paraprotein monoclonal proliferation, and IgM is largely present in the intravascular circulation. So simply we have to reduce them. In emergency, if there is emergency and the patient condition is not good, so we can go for plasma pheresis, okay, for hyperviscosity syndrome. Okay, so we can go for plasma pheresis. Okay, and of course, like when we go for plasma pheresis, it decreases the level of IgM in the blood. Okay, so that's all about Waldenstrom macroglobulinemia. And this concludes all the topics of hematology. And our next lecture will be about, we are going to start nephrology, and then we will move to the final topic, uh, final unit, rheumatology, right? So that's it, guys. I hope you understand hematology well. Okay, and see you in the next lecture. Thank you so much.